Welcome to Talking About Glaucoma, episode number 34 for May 7th, 2021. Here's another recording from the vaults that is getting to see the light of day. It's one of 3 episodes recorded in person back in late February 2020, just before COVID derailed us all from business as usual. My apologies for the sound quality on this one. I was experimenting with a BOYA dual lapel mic, recording directly from my phone. Big mistake. Future recordings from episode 37 onward will go back to my professional recording gear. Email me at podcast@iguy.org if you would like to be on the show to discuss a topic in glaucoma, or if you have questions that you would like to have answered on a future episode. Check out West Coast Glaucoma on Instagram for short-form videos that can also be found on my Rob Schertzer YouTube channel, where your subscription will help improve future content. In this episode, I talked with Daniel Laroche. We have crossed paths for many years at conferences, having both started our practices at the same time, but this was the first time we sat down to record our conversation. Daniel Laroche is Director of Glaucoma Services and President of Advanced Eye Care of New York. He is affiliated with the New York Eye and Ear Infirmary and Assistant Professor of Ophthalmology at the Mount Sinai School of Medicine, New York. I'm Rob Schertzer, a Vancouver, Canada-based glaucoma specialist, podcaster, and health IT expert, and we're talking about glaucoma. Daniel Laroche, welcome to the show.
Thank you, Rob.
These days there are a lot of different surgical options for glaucoma, and there are so many different things that we have to think about in terms of what's going to be effective, included in that, I guess, is cost effectiveness too, and where the population is that we're operating on. So I understand you have a surgical technique that I've seen your videos for too.
Okay.
If you want to maybe explain your
Okay.
external
I'll
suprachoroidal approach.
I'll start with
when you would use it.
Okay, I'll just briefly start with the paradigm shift in terms of the way I approach glaucoma. Initially, I used to approach glaucoma with medical therapy. That's what was taught with the preferred practice pattern. But with the recent MIGS data that's come out, the studies that come out, cataract surgery has a profound intraocular pressure lowering effect early on. And it's much safer than trabeculectomy. A couple of studies that come out to mind, the Morse Field Eye Study and the Collaborative Initial Glaucoma Treatment Study, showed that trabeculectomy patients did better IOP lowering compared to medical therapy, but they had more complications.
There's always that trade-off.
And so what I'm seeing in my practice is taking the cataract out and doing MIGS. It's a much safer procedure with low complications and excellent efficacy in lowering the intraocular pressure. So that's my first go-to. And currently, items like cataract hydrus, cataract omni, cataract cahook, those types of MIGS, I've had very good results. I did like the CyPass when it was available, and my family's from Haiti, and I have relatives in Haiti, and as Haiti is not a wealthy country, and there's a lot of glaucoma in Haiti, so I always thought, well, how can we make something affordable like the CyPass for Haiti? Right. And so that's how I came up with the AB external suprachoroidal.
And just for the audience, the CyPass is a suprachoroidal shunt.
Yeah, CyPass was a suprachoroidal shunt.
It's ab internal.
So ab internal
through the inside.
Exactly. And so I started to research the size of the CyPass, and internal diameter is about 300 microns, similar to the tube shunts that we use, like the Omni valve and the Barber valve. And those are FDA approved for intraocular use. So I cut the silicone out, and I was used to placing tubes in the sulcus, in ciliary sulcus. And I knew that tube shunts would be safer in terms of position in ciliary sulcus as opposed to in the anterior chamber next to the cornea. And I was also used to placing tubes
in pseudophakic eyes.
In pseudophakic eyes. And I was also used to creating a scleral flap. And I became comfortable with the suprachoroidal space from draining choroidal effusions. And I realized you could cut down through the sclera to the choroid, and it was a spongy material. It's not like you're going to get an immediate hemorrhage like we thought of when we were doing residency training. And so yeah, and a pseudophakic patient that needed additional surgery, but I didn't want to do trabeculectomy because despite having done perfect trabeculectomies many years later, sometimes people can get endophthalmitis. And I've had a couple of cases where 20 years later, after successful trabeculectomy, people have gone abroad, got an infection, came back, and they've lost the eye.
Right. And there's still that statistic 1% chance per year.
Yeah.
Also, if we're talking about patients getting surgery at a younger age, if they're getting surgery in their 40s or 50s, they have a big chance in their lifetime of getting that endophthalmitis.
So that's how I came up with that technique. And I did it in a patient. And with these techniques, just like the side patch, you can get initial hypotony, and I leave viscoelastic in the eye. But she healed and she did very well. Good visual recovery, good low intraocular pressure. And I started to continue to do it more. And those patients who, after cataract or goniotomy uh, at the time of Cahook, if they didn't do well with medical therapy, that if they needed something else, I would do the suprachoroidal procedure. Uh, and so that's how we got started with that.
So what is the tubing material that you're using that keeps this as a low-cost procedure?
Okay, well, initially I had cut the silicone from the Ahmed valve tubing. Now I use the New World Medical tube extender. And that costs about $100. That's Ahmed valve could be about $500. Well, that's a little more expensive. In developing countries, the Oralab tube is available for $30, and they can cut the silicone from the Oralab tube.
Okay.
That's approved for intraocular use. There is silastic tubing that can be used. That's as little as $10. Sterile silastic tubing.
Right. So like catheter tubing is.
Yes. The thing is, although it's made from the same material, like a medical grade 6 silicone from Dow, um, the tubings I mentioned previously are approved for intraocular use, and some of these others are not necessarily approved for intraocular use, but it's the same material and it's sterile. So I have used them successfully in developing countries because you can get them for as little as $10, and it works well. We've used it in Ethiopia and Haiti and Nigeria.
Actually, a colleague of mine used to keep some silastic tubing available when he was faced with patients who had previous retina surgery and had a buckle around the eye. And if there just wasn't room to dissect away to get in any sort of tube shunt, you would just take silastic tubing, get it just underneath the buckle, and
I think they call that modified socket.
Yeah, and Gord Douglas was doing
that. Yeah, and so this is a nice affordable option because globally, you have 60 million people with glaucoma. They're not going to be able to afford some of the more expensive products we have in the United States. So when I do travel abroad, I try to work with the local doctors who are good at cataract surgery.
Yeah.
And then once they have good hands for like small incision cataract surgery, they're halfway there. And then we add affordable techniques like using a 23 gauge cystotome made by Eagle Lab. It's a straight 23 gauge cystotome with a bent needle. It's similar to the Cahook blade that costs about $4. Cahook blades about anywhere from $300 to $400, and the suprachoroidal technique. And so that allows you to have 2 to 3 procedures there that's affordable, that can be done. Can be done by the local surgeons. Nowadays, in pseudophakic patients, to get maximum efficacy, I'll do the combined goniotomy and suprachoroidal tube. We have about 30 patients and 6-month follow-up data. The intraocular pressure pre-op is about 21 on 4 medications, and at 6 months post-op, it's 12 on 1 medication.
That's really great.
With no bleb. So combination microinvasive glaucoma surgery, I think, is going to be part of the path of the future. It's still early. We're trying to get more data still.
Right. Yeah, it would be great to have like 1 year and 2 and 3 years.
Yeah, it's really still early.
Because we've seen with some other mixed procedures looking great, and then 3 years just kind of trails right now.
Absolutely. So it's a really exciting time in glaucoma. And, here in America, we have, the Hydras, the iStent, and more expensive devices. But, I like to think also to make glaucoma surgical treatment affordable and accessible to the rest of the world in resource poor areas that may not have these things.
Yeah, and things aren't, it's not rich everywhere in the United States either. So it's something that should be considered here with the really high healthcare costs.
That's true, because nowadays at hospitals and insurance companies, they're looking at your utilization
Right.
of devices, OR time, and things of that nature. So sometimes I will resort to these less expensive techniques to reduce my costs to the hospital, uh, to the insurance companies as well, and to make it affordable.
Yeah. I'll include a link in the show notes to your YouTube video to show the actual technique. But if
Okay.
you could want to just explain it briefly. So you do the cataract removal first.
Okay. Yeah. First, I'll do the cataract removal, and then I'll explain to you the combined technique that I do.
Right.
I'll do the cataract removal first. Then I fill the anterior chamber with a viscoelastic like a Helan GV or Endocoat. And then I'll rotate the patient's head 45 degrees away from me and tilt the microscope 45 degrees away towards me.
Okay.
And then use a direct gonio lens, like a Katina disposable lens or a Swan Jacob lens. And with viscoelastic, I'll place on the cornea and I'll focus down to the surface of the cornea, place the gonio lens on it, and then focus down with the foot pedal to make sure I have a good view of the trabecular meshwork. And then I'll go in with a 23 gauge cystotome. That's a straight 23 gauge cystotome made by Eagle Labs. So it's straight, and you can go in and unroof the canal. Sometimes I'll unroof part of it, and the other part you can use a Sinskey hook and open up the canal as well with a Sinskey hook. And so you'll have a nice goniotomy there. And I'll leave viscoelastic in the eye because you will get a little bit of heme reflux with this. And I rotate the head back and I put the microscope straight back into the upright position. Then I'll do an inferior temporal conjunctival periodontal, and I'll give a peribubble block for this portion, okay? Because they do feel that dissection. So I'll give a peribubble block on a table.
And infratemporal, that's chosen because you're doing a temporal clear cornea cataract extraction?
Yeah, I'm sitting
So you're
clear
in
cornea
position.
temporals. I'm already in the temporal position. And so I do inferior temporal. Plus, I like to preserve the superior conjunctiva for any future glaucoma surgery for the future. So I'll do inferior temporal. I use hemostasis to maintain cautery. And then I'll use a 0.124 set and a crescent blade. And I'll cut a scleral flap with the hinge about 4 millimeters by 4 millimeters. And the hinge is inferior. So I lift the flap up and the hinge is inferior. Okay? And then I'll make a paracentesis superiorly through the cornea and inject a little more endocoat to create the space between the iris and the intraocular lens, okay, and the sulcus. And I'll use a 23 gauge straight needle, approximately 2 millimeters from the limbus, and make an incision beneath the scleral flap into the ciliary sulcus. For this part, the pupil is dilated. Okay, it's already dilated from the cataract surgery. So the pupil is dilated for that. And then I'll cut the tube, I'll take the tube extender, I'll cut it with a bevel, and I'll have the bevel facing the intraocular lens. And I'll insert it through that incision. And then I'll withdraw it a little bit. I'll make sure I'm in the ciliary sulcus. Sometimes you have to be careful. You don't want to be too anterior up against the iris. And I'll verify the position of the tube with a cyclodialysis spatula to make sure I'm in front of the IOL. You want to make sure you're not behind the intraocular lens. Okay. And on a rare occasion, if I don't have enough space in the ciliary sulcus because of the anatomy of the eye, I may put the tube in front of the iris. But I like to put it behind the iris to minimize the risk of corneal edema. So then I'll retract the tube partially so it's not in the visual axis. And then I'll use a tenoprolene suture and tie it through the tube, through the sclera, and tie it with 3 throws. I like to put it through this tube so the tube does not move. Okay. Then a couple of millimeters behind that suture, I use a crescent blade and make an incision through the sclera to the suprachoroidal space. That's within the space of the scleral flap. And I gently just go back and forth, and usually you'll feel the resistance decrease, and in the space, and I make it wide enough to be able to insert the tube. And I'll cut about 2 millimeters of the tube just past that incision. And with a 2.12 forceps, one I'll grab the sclera, the other one I'll grab the tip of the tube and just tuck it in. And I'll just tuck it in. Exactly. And I cut it flush. There's no bevel, just flush. And I tuck it into the suprachoroidal space. Then I close the flap, suture it with 2 interrupted aortic sutures, close the conjunctival peritomy with running locking aortic sutures. I'll remove some of the viscoelastic, not all of it, because I do anticipate hypotony. So I'll leave some of the viscoelastic in the eye. I give intracameral Vigamox, subconjunctival Kenalog. I'll have the patient sit up after the procedure to reduce any backflow of episclerovenous pressure, okay, because we do have that goniotomy there. You may see a little bit of heme or small hypema the next day. This will usually clear as the eye autoregulates over the next week. And you should get a little pressure. And I see the patient with steroids postoperatively 4 times a day, antibiotics 4 times a day. I'll use that for about 3 weeks. Antibiotics will probably use for 7 to 10 days, but the steroids I'll keep on for about 3 weeks and then taper it off. And I'll see them post-op day 1, maybe 1 week, 3 weeks.
So why both the goniotomy and the suprachoroidal? Because the goniotomy would be the opposite end. It would be nasal.
Yes.
You're going across the AC for that.
We've gotten a little bit better results with that combination. The initial suprachoroidal alone, intraocular pressure would be about 21 or 4 medications and come down to about 12, 13 on 2.5 medications. Okay. So I wanted to try to get a little bit better because there's been some other publications about combination MIGs.
Right.
And I just wanted to try this out, and I've been doing that with success.
Yeah. So if you're getting down to 12 and 1 medication, that's like a 1 year post-tube shunts, which is really remarkable with a much more cost-effective procedure.
Yeah.
And you still have the space saved up top for
exactly
travel tube shunts. So
exactly.
Really good.
Exactly.
Sounds great. Keep me posted on the long-term follow-up.
We will. We do have a cohort that we're following. We've also applied for IRB approval at the hospital to follow this long-term cohort, and it's exciting. And I think that it's going to give a lot of hope to people in resource-poor areas, so they have like some concrete procedures that will work. Yeah. And this, taking the cataract out, being able to do these 2 procedures, it's really fabulous. I think because I've not done a trabeculectomy in the past year. The only thing I've done is a glaucoma tube shot for neovascular glaucoma and uveitic glaucoma. I do not recommend the suprachoroidal tube for neovascular glaucoma or uveitic glaucoma. There are a couple of studies that show that it doesn't work as well as the OMED valve. But except for those 2 types of glaucomas, where I've used tube shunts, right. I have not need to do trabeculectomy.
There was 2 cases of blood aqueous barriers violated.
Yeah. So for me, this has led to the death of trabeculectomy.
Oh, it's such an effective procedure, beloved procedure.
I was a big trabeculectomy person. I did a lot of trabs every week, but that long-term risk of endophthalmitis, bleb dysesthesias, this large disfiguring bleb, sometimes ocular surface disease, you don't get that with this.
Right. And also unpredictable, whatever looks great on the table, you don't know what you're going to see the next day, yeah. Okay. Well, thanks for talking today.
Thanks for having me. It's been a pleasure.
That's our show for today. Talking About Glaucoma is a podcast of indeterminate frequency and duration. It's available for free on Apple Podcasts, Spotify, Google Podcasts, Pocket Casts, and wherever fine podcasts are curated. Please rate this podcast on Apple Podcasts, subscribe to it, and tell your friends about it so that it can reach more listeners. Follow me at West Coast Glaucoma on Instagram, Talking About Glaucoma on Facebook, and Rob Schertzer on YouTube. Drop me a line at podcast@iguy.org with your show ideas or questions you would like to have answered on future episodes. Keep informed to prevent needless loss of vision from glaucoma. Stay safe, wear a mask, and get vaccinated. See you next time on Talking About Glaucoma.